Hi everyone, welcome to Hub Bites. I'm Sanil Rege, consultant psychiatrist. If you're new to the channel, we cover all things psychiatry and mental health related, so don't forget to subscribe if that's your thing. Today I'll be taking you through antipsychotic medication. Now, the word antipsychotic medication can actually often lead to a certain amount of stigma because it's considered as quite a strong medication in a way, or a medication that's prescribed only in psychosis. So often people think, well, why do I need a antipsychotic medication? I'm not psychotic. Our understanding of psychosis is often linked to delusions, hallucinations, erratic behavior. But from a neurobiological perspective, psychosis is very much about the mesolimbic system being affected and excessive dopamine release. This is the dopamine hypothesis of psychosis. We see the same hypothesis in schizophrenia, in bipolar disorder. But as we know in schizophrenia, we also have other parts of the brain affected, the frontal lobe, where we need adequate dopamine, the nigrostriatal pathway for movements, where we need adequate dopamine. So essentially, antipsychotic isn't just about treating the psychotic symptoms. By understanding its neurobiology and psychopharmacology, at lower doses, they have a range of additional properties as well. They have antidepressant properties, anti-anxiety properties, sleep promoting properties, etc. So they can be used in a range of other disorders as well. And the aim of this video is to give you an understanding of the psychopharmacology of the antipsychotic medication, to understand, of course, where it can be used and how it can be used. So let's jump into it. Antipsychotics are a type of psychiatric medication that are available in prescription to treat certain disorders. Antipsychotics can be prescribed to be taken in various different ways. Most commonly, one will take them by swallowing them, so oral form, tablet or liquid, but some of them can be prescribed as a depot injection. And there have been developments in the sense of initially every 2 weeks, or monthly. Now we've got 3 monthly and we've got 6 monthly injection as well. So this is a slow release, slow acting form of medication, the depot long acting injections, that can help with compliance. And we know that taking medication daily over an extended period of time can, is tough and can lead to long compliance. Often what we want is we don't want those medication levels to fluctuate too much. We want a nice steady state level, and that's where long-acting injections can help. Antipsychotics drugs or medications, it's important, they don't cure psychosis, but they can help to reduce and control many symptoms. Having said that, there are a group of patients with psychosis, with schizophrenia, that may require antipsychotic medications for a certain period and then can stop it and the illness doesn't come back. But we don't know who or what group is that. We can't predict that particular group. But absolutely, some patients may have a psychotic episode and might not need medication ever again. But that's a discussion to have with the doctor and know whether medication needs to be or can be reduced. It needs to be done very, very gradually because there are other dopamine withdrawal symptoms or rebound psychosis if it's done too quickly. So we know with psychosis or schizophrenia, we have a range of symptoms. I've covered that in Deconstructing Schizophrenia video. But delusions and hallucinations such as paranoia, hearing voices, anxiety, serious agitation can occur, incoherent speech, muddled thinking, confusion, violent or disruptive behavior, mania. So these are all sort of range of symptoms that can occur. So let's think about the dopamine pathways. Firstly, because once we understand that, we know how the medications act. So firstly, we know that here, by the way, so it's not very clear because it's in white, but I'll read it out. So it says substantia nigra to striatum. So this is where movements, it's known as the nigrostriatal pathway. Then we've got the next pathway, which is for positive symptoms, hallucinations, delusions, erratic behavior, disorganized speech. This is the mesolimbic pathway from the ventral tegmental area to the nucleus accumbens, right? The mesolimbic pathway responsible for positive symptoms. Then we have the affective symptoms, mood-related symptoms, and you can see this one is again from the ventral tegmental area to the frontal lobe. Right, frontal lobe we know is linked to mood. Then we have, again, same tegmental area to the other part of the frontal lobe, which is the dorsolateral prefrontal cortex, where we have cognition, but also a group of symptoms known as negative symptoms. So cognition is our executive function, attention, concentration, decision-making, focus, motivation, ability to detect errors, set shifting, multitasking, all of that is cognition. And negative symptoms is often apathy, alogia, reduced speech, can't be bothered kind of thing, inability to want to engage in activities, amotivation. And then we have the other parts where prolactin is involved. So prolactin, we know that they're on the lactotrophs, where of course those lactotrophs result in lactation. The whole pathway, pituitary lactotroph signaling for lactation to occur. Dopamine plays an important part. There are dopamine receptors. So what happens is, this is the tuberoinfundibular pathway from the hypothalamus to the pituitary. So what happens is, if dopamine's blocked there, you get elevated prolactin. And dopamine is necessary to keep excess prolactin secretion under check. So you can see you've got movements, you've got positive symptoms, affective symptoms, cognition, negative symptoms, and prolactin. That is what psychosis looks like. And I'd add another one not related to the brain, but we've got metabolic syndrome as well. So what my aim is in treatment is I want to reduce these positive symptoms that are causing a lot of problems, but I want to ensure that the mood's okay. I want to ensure cognition's okay, that there's no increased prolactin, because increased prolactin has problems, sexual dysfunction, lactation, galactorrhea, gynecomastia, which is breast enlargement, osteoporosis over long term, lots of side effects. And we want to make sure the movements, they don't result in akathisia, which is a terrible side effect. They don't result in Parkinsonian side effects. Done a video on akathisia, by the way, as well, and you can see these different movement disorders that's present. I don't want tardive dyskinesia, the chewing movements that can occur, and for that, dose adjustments are required. If you're looking to learn more about this topic and discover a range of other stimulating psychiatry courses, then don't forget to subscribe to the Academy by PsychScene. So they fall into two categories, antipsychotics: first generation, second generation, also known as first generation typical, second generation atypical. So first generation antipsychotics only block dopamine antagonists. So what they do is they can reduce positive symptoms, but they cause a lot of side effects because they block dopamine in the frontal lobe, in the tuberoinfundibular pathway, increasing prolactin. They block it in the nigrostriatal pathway for movement, so you get the stiffness and a range of other side effects. So what they did was they came up with the atypical antipsychotic, where still you get that D2 action, which you want to treat the positive symptoms, but they use that 5-HT2A antagonism, which means blockade. And what this 5-HT2A antagonism does, it actually promotes dopamine release in these areas so you don't get those side effects, or minimizes the side effects. Of course, if you prescribe too high a dose, you end up with the side effects anyways. So first generation antipsychotics, they're referred to as typicals. There's a range of them. We'll look at what they are. They all act in similar ways and can lead to similar side effects, mainly neuromuscular side effects, which is the extrapyramidal side effects we call them. But they're not all the same. Some may cause more movement disorders depending on the dopamine blockade. Second generation, referred to as atypicals, they're known to lead to less EPSEs, less prolactin issues, less sexual side effects. Having said that, everyone's different. Some individuals can be very sensitive to even lower doses of this. So this is in general, doesn't mean that for every person they're safe or don't lead to side effects. But second generation antipsychotics may be likely to cause more serious metabolic side effects. Not all, but some of them have antihistaminergic properties leading to metabolic dysfunction, rapid weight gain, increased triglycerides, increased LDLs, and increased blood glucose. So here are the antipsychotic medications in Australia. This may differ from other countries, but essentially we've got first generation antipsychotics: chlorpromazine, flupentixol, fluphenazine, haloperidol, pyrazine. These are first generation. Second generation are more commonly used now. We've got amisulpride, aripiprazole, asenapine, brexpiprazole. Second generation clozapine for treatment-resistant schizophrenia, lurasidone, olanzapine, paliperidone. We've got quetiapine, cariprazine, risperidone, sertindol. Sertindol is out of favor because it prolongs QTC interval. We don't want it prolonged because it can lead to arrhythmias that are problematic. We don't tend to use sertindol. And ziprasidone has a similar side effect of prolonged QTC. It's kind of fallen out of favor. So one of the things is, most of them we've traditionally thought is D2 5-HT2A. This is D2 5-HT2A. This is D2 only. But there are newer agents that don't have dopamine blockade at all. So one of them is known as pimavanserin for Parkinsonian psychosis, which is an antagonist inverse agonist at the 5-HT2A receptor. So it's kind of telling us there's more to psychosis than just a dopamine. And we do know that because there's glutamate pathways involved as well. But this is interesting. This is a recent article, as you can see, April 2020, a non-D2 receptor binding drug for the treatment of schizophrenia. You can see an oral compound, doesn't have a name yet, but it's called SEP363856, that does not act on dopamine D2 receptors, but has agonist activity against the TAR1 receptor, trace amine associated receptor. Now, this TAR receptor is a really fascinating one because it's come up in psychedelics, it's come up in clozapine, and it's come up in MAO inhibitors. So TAR1 receptor in dimethyltryptamine has come up, DMT, psychedelics. And of course, there's a 5-HT1A receptor agonist as well. So what we're seeing here is a new class of antipsychotic. So there's more, hopefully better tolerability, hopefully better efficacy as well. But it's in the early stages, we'll know more. How do they work? So we're going to stick to the traditional, what's available at the moment, and talk about those. Conventional antipsychotics are first generation or typical, D2 only. Atypical, add on a 5-HT2 antagonism, and you get reduction of positive symptoms, but the other cognition, negative symptoms, all of those things aren't caused because of the 5-HT2A promoting dopamine release in those pathways. So 5-HT receptor, as I mentioned, what it does is when you activate it, it inhibits dopamine release. Obviously, if you block it, then it will promote dopamine release. Similarly, activation of the 5-HT1A receptor, it releases dopamine. So you get these additional sort of benefits with the 5-HT2A antagonism. Then we have what's called a partial agonist. This is the Goldilocks effect. Aripiprazole, brexpiprazole, cariprazine. What this one shows here is essentially we don't want the porridge too hot, we don't want it too cold, we want it just right. That's what a partial agonist does. So you can see here when it's too hot in a way, you can see this is the dopamine postsynaptic neuron. And we'll see here when it's too cold what happens as well. So when a partial agonist is prescribed and the porridge is too hot, it will bring it to a milder end of the spectrum. That's what it will do if the porridge is too hot. It'll bring it to optimum. It'll cool it down. So in other words, what that means is if there's too much dopamine, it will act as an antagonist. It will block the activity of dopamine. Whilst if there's too little, it's too cold here, then this will start acting as an agonist and promote dopamine release. So that's what a partial agonist does. Goldilocks effect, not too hot, not too cold, just right. There is another way of thinking about it. We call it the dimmer switch effect. So if the light's too dim, it'll bring it up. If the light is too bright, it will bring it to the middle. So as you can see here, if there's maximal activity, it'll bring it down to optimal. If there's basal activity, too low, it'll bring it down to the middle. In other words, similarly here, if it's too little, it'll bring it here. If it's too much, it'll bring it here. Okay, this is the dimmer switch effect. Okay, generally speaking, antipsychotic medications, as I've mentioned, work by blocking that D2 receptor. So just a quick recap. Conventional block the D2 receptor and improve positive symptoms, but unfortunately, they also block D2 receptors in areas outside the mesolimbic pathway. This can be associated with worsening of negative symptoms, depressive symptoms, cognitive symptoms associated with the illness. Second generation, they block D2 receptors as well as 5-HT2A. So what happens is they treat both the positive and the negative symptoms. This sort of in a simple way. What are the side effects? Now, antipsychotics, there is no doubt they come with their side effects. And the aim of the psychopharmacologist, the clinician, is to ensure that these side effects are minimized or treated proactively. Possible side effects: dry mouth, dizziness, anticholinergic effects often. Weight gain that can lead to diabetes absolutely needs to be treated proactively, or consider metabolically friendly such as lurasidone, brexpiprazole, or metabolically friendly aripiprazole. Now, of course, all of this needs to be discussed with the doctor because some agents may work and others may not. And side effects then need to be treated rather than choosing another agent. Blurred vision, movement effects, that's the extrapyramidal side effects. Sedation can occur because of the anticholinergic property. Loss of menstrual periods in women, that's often due to elevated prolactin. Risperidone and paliperidone, most notorious to do that, along with amisulpride, elevated prolactin. Fluid retention, dry mouth, sexual problems, and headaches. So this is from a meta-analysis, as you can see, by Loixt, 2013. But there is a more recent one as well with very, very similar results. So you can see if it's extrapyramidal side effects, which is the movement problems, haloperidol, which is a typical dopamine blocker, has the most. Placebo becomes better. Whilst clozapine tends to be best because it has a hit and run mechanism. Olanzapine as well. Prolactin, as you can see, we have paliperidone, risperidone really problematic, whilst aripiprazole tends to be good. Aripiprazole, brexpiprazole, or prolactin sparing. In fact, aripiprazole can reverse elevated prolactin. QTC, lurasidone, aripiprazole, top, best. Whilst sertindole is problematic and ziprasidone is problematic. With sedation, obviously the ones with antihistaminergic property will be problematic. Clozapine, olanzapine, quetiapine. And these also, because they have antihistaminergic property, are also associated with weight gain. Whilst the best ones tend to be ones that have a lower antihistaminergic property. Lurasidone, aripiprazole, paliperidone, amisulpride. Weight gain, problematic, without a doubt, clozapine. Olanzapine is problematic, quetiapine is problematic, risperidone is problematic, whilst haloperidol, ziprasidone, and lurasidone, aripiprazole tend to be the best. So often, metabolically friendly ones will be aripiprazole, brexpiprazole, lurasidone, cariprazine are the ones. Now this is because it's an older one. Cariprazine is not in here, but cariprazine tends to be prolactin sparing, tends to be favorable for weight gain, tends to be favorable with regards to sedation. Its main side effect is akathisia. So to manage or reduce side effects, what the psychiatrist will often do is, there are 4 steps. Either one may consider wait and watch because the side effects could reduce. The next step is either changing the dose, reducing the dose, adjusting the dose, or switch, prescribe a different medication, which needs to be done appropriately. Switch takes time, it needs to be done cautiously. Or suggesting to take the medication at a different time of the day sometimes can help, or augmentation. So say for example, there's weight gain and one can't stop the medication, one can add things like metformin or topiramate, etc. All of this requires a multidisciplinary intervention, discussion with the doctor, endocrinologist involvement, etc. But all of these things can work very, very well. And of course, diet exercise programs can also be very, very helpful. I hope to do a more detailed video on, say, metabolic dysfunction, etc. But I've written about all of these things on shikescenehype.com in much, much more detail. So I hope that you found this video useful. If you liked it, leave us a like. And thank you so much for watching and supporting our channel. I really do appreciate it. And I look forward to seeing you in another edition of Hub Bites. Until then, take care and stay safe. Bye-bye. Synthesizing complex material in psychiatry to simplify your practice.